Good afternoon, everyone. Good morning to others who are joining us from the left coast or the Mountain Time Zone. Welcome to the National Center for Medical Legal Partnerships Health Center MLP Planning, Implementation, and Practice webinar series. It is a pleasure to have all of you join us today for session 7, and one that I think will be extraordinarily fruitful and hopefully very informative. And today's session is entitled MLPs in EMR, The Next Frontier, One System's Success. Today we'll be focusing on folks from New York City, from LegalHealth and the Health and Hospitals Corporation. And I'm very excited as we go forward to really impart, hopefully, a lively discussion and a thoughtful presentation on this really wonderful integration of EHR into a medical legal partnership. Next slide, please, Reha. As many of you know who've already joined us for many of the 6 prior webinars and other events from the National Center, we have a kind of a protocol for housekeeping in this webinar series. The attendees, all folks are muted. If you do have a question or would like to provide some information, please don't hesitate to type your question or information into the chat, the Q&A pane, and that chat will also be open. So there's both the Q&A and the chat. And we will be monitoring, as I'll tell you in a moment, the Q&A and the chat, and then potentially or hopefully invite some of you in to share some of your ideas, thoughts, and feedback on the information that we're presenting today. If you would like to activate captions, please select live transcript and show subtitle. And as always, this webinar will be recorded and shared at the National Center's website in the link you see below, medicallegalpartnership.org/resources. And please note that the slides will also be shared on the resource page as well. Next slide, please, Reha. Again, as I said, we definitely want you to be participants, not just observants to this webinar. So we welcome your participation both in the chat, and if you'd like to raise your hand to comment, we will certainly do that. And we invite you to do so. Next slide, please. So most of you who've attended these webinars are familiar with the kind of alphabet soup, if you will, of abbreviations that exist in the world of medical legal partnership: MLP, the health center world, CHC, the Human Resources and Services Administration, HRSA, the sponsor of these webinars, Legal Services Corporation, those of you who are members of legal services organizations that are LSC participants know what LSC means, and obviously federally qualified health centers, FQHC. So alphabet soup reigns in our world, but please also, if you do not know of or are unfamiliar with an acronym, please type it in the chat and we will do our best to answer as soon as possible. Next slide, please. As I just stated, this is a HRSA-supported webinar, the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And it's part of an award to the National Center. And the contents are those of the authors and do not necessarily represent the views of, nor an endorsement of HRSA, HHS, or the U.S. government. For more information on HRSA, of course, you may visit their website at hrsa.gov. Next slide, please. This, again, as I said, is part of a webinar series, the Planning, Practice, and Implementation series, the PIP series, which is a partnership of the National Center, the NCMLP, and the Texas A&M University Institute for Healthcare Access. These webinars are produced to support health center-based MLP planning, implementation, and practice. But obviously, anyone who participates can be the beneficiary of the information and the resources provided by this partnership. The partnership has produced an incredibly valuable toolkit. I'm sure most of you have already accessed it, but if you would like to do so, the link to the toolkit for Health Center MLPs is available on this slide. And that is obviously slide number 6 for those of you keeping score at home. And again, we would like to make this an active learning experience, not just an observant passive learning experience. So please don't hesitate to raise your hand, and we will call on you during the course of the webinar. Next slide, please, Reha. We would like to start with, as we usually do, a poll. Let's see who's in the audience today. What type of organization are you from? Does your organization have a medical legal partnership? And number 3, how does your partnership exchange data and information between entities? So if we could begin the poll, we'll keep it open for a little bit, and then we will see what we have. All right, let's give it about 10, 15 more seconds. Reha, please. Still coming in. All right, why don't we end the poll? Thank you. So as we can see, this falls along the lines that has been pretty consistent throughout, pretty much even almost between healthcare and legal services, some folks from academia, and one other. If someone who has typed in the other would just put in the chat where you're from, that would be interesting, I think, for us to find out if you're willing to do that. And that would be very helpful. Does your organization have an MLP? So this is a audience rich already with MLPs, and a few of you do not. And then number 3, how do you exchange information? And again, this is a pretty broad spectrum. There is a paper-only crowd still in existence, so a small number. Email, about a third of you. Legal team can receive referrals and limited information through a system. That's interesting, at about 30% as well. The EHR exchanges data, so one of you has that. And after referrals made, we do not exchange information. Very interesting. And then other as well. So as I think Bethany's just pointed out, please don't hesitate to type in the chat how you do exchange information, because I think that would be very helpful for us to figure out. All right, well, thank you for participating in that. Why don't we go forward? And thank you. All right. All right, so this is where we are in our webinar series. We're up to number 7, consent and information sharing. And it's 7 of 9, at least up and through June. And then working through the next series, which will begin starting in the summer and into the fall in parts 2 and 3. So this is a ongoing endeavor that HRSA has supported with the partnership and the folks at Texas A&M Health. Next slide, please. So I am the moderator today. Bethany Hamilton, who is the co-director of the National Center for Medical Legal Partnership, is in the background today and always providing helpful and thoughtful additions. So Bethany will always provide probably significantly more than I can share, but she's online as well. And Keegan Warren, whom I'm sure many of you know or from our previous webinars, has participated and led many of these, is off on her honeymoon. So we wish her well and hope to see her back fairly soon. Next slide, please. Today, we are really fortunate to have two incredibly thoughtful guest presenters. And as you can see, Emily Foote and Julie Brandfield. Emily is the Senior Director for Social Determinants of Health at the New York City's Health and Hospitals Corporation. She is, that is, of course, the largest safety net hospital system in the country. In her role as Social Determinants of Health team, Emily oversees strategy and operations for NYC's H&H's medical legal partnership with the New York Legal Assistance Group, that is Julie's organization, and the LegalHealth division of NYLAG, then led the design and implementation of the first of its kind EMR-based legal referral and scheduling system. Julie Brandfield, whom I've known for many, many years, establishes new clinics, supervises legal health staff attorneys, and oversees the training curriculum for hospital partners. She engages in policy initiatives led by LegalHealth on medically homeless and immigrant access to Medicaid. She has extensive litigation experience, including employment and in insurance law. And it's really a pleasure to have both Emily and Julie participate today. I can't think of anyone better to really talk about how to tackle this, what can be an enormous endeavor to integrate a medical legal partnership into an EHR in two separate systems. And I think you will find it just as fascinating when we get into the meat and potatoes of all this. Next slide, please, Reha. So we wouldn't be able to put these webinars on without the incredibly adept support of Reha Manescond-Asami, who is the Senior Research Assistant for the National Center for Medical Legal Partnership. Reha is also handling a lot of the technical aspects of today's presentation. And again, we thank her for her expertise and her ability to provide incredible support to everyone on the team. Next slide, please. So quickly, for those of you who either were participating in or weren't able to attend Section 6, this is what transpired. The learning objectives from exploring health center versus hospital-based MLPs from the Georgia Legal Service Program are posted here. Those of you who were able to participate know that it was a really thoughtful presentation. Those of you who are not, the recording is available, as were the slides from the prior presentation. Next slide, please. So today's larger topic covers patient consent and information sharing. The following slides, next slide, please, is really a guidepost for folks who would like to learn a little bit more about how MLPs can structure information sharing from the concept of referrals, coordinating staff, and dealing with an organizational idea and concept of linking referrals to the actual work. There are a lot of resources available from slides 15 through 21. I urge you to take a look at them. So I'm seeing presenter, but not the slides. So Reha, I don't know if you see that. Maybe we can do something to increase the slides. It's okay on my end, but I just want to make sure that folks, maybe it's in terms of your settings, in terms of reversing the presenter and the slides. That could be it too on Zoom. So, all right. So next slide, please. So again, there are a number of different kind of models and paradigms for consent and disclosure. There's a lot to learn from these slides, but the bottom line is this is really the heart of how MLPs integrate into the healthcare system, right? Whether it's a community health center or a large hospital system. And these are really important concepts about consent for the legal partner to obtain information from the patient, consent from the medical partner to share information directly to the legal services folks or to the lawyers, how the referrals take place, how the referrals may be different from actual client referrals to curbside consults, and how these referrals kind of cross boundaries in a thoughtful and organized fashion. Next slide, please. So again, I'm not going to go through all the questions, but these are fundamental questions that need to be asked as you're creating and plowing through the integration of a healthcare and a legal system. Are there certain requirements? Are there confidentiality issues? What systems are already in place, and can they augment and enhance medical legal partners? And the bottom question, I think, is the key one. What kind of information and how much information can and should be shared? And of course, these are questions that get into the legal and the ethical responsibilities and constraints of both systems. Next slide, please. So how do you integrate legal services into workflows and systems? And that's really where we're going to live today for the next hour and 15 minutes or so. Next slide. What we've done is we've been able to post some really important and I think excellent and thoughtful opportunities for you to see some paradigms and resources for you to use in terms of EHR, in terms of access to patient protected health information. Next slide, please. So these are a couple of resources, all linked in the slides. The leveraging the EHR to link health centers patients with medical legal partnership services. An excellent resource, an issue brief for Iowa, Montana, and Texas and how they did it. Next slide, please. And then electronic exchange of data, closing the loop, and the do's and don'ts of MLP curbside consults. Both really thoughtful and helpful guides for those of you who are working your way through these issues. Next slide. So today we are going to actually, and I'm finally going to hand over this presentation to Emily and to Julie to talk about MLPs in EMRs. How one system, and not just any system, but the largest public health system in the country, was able to do this through really thoughtful planning, hard work, some fits and starts, but the story is a good one, and the outcomes are really important. So let's take a look at today's learning objectives. Next slide, please. Number one, understanding the impetus for building MLP referrals in an EHR or EMR. Number two, the nuts and bolts on how this was actually done. And number three, what lessons were learned and what the next steps were after the system was built. Next slide. So it is my pleasure to turn the presentation over to both Julie Brandfield and Emily Foote, and to let them take you through this journey, which is really remarkable, and I think hopefully can be really a guidepost for many of you out in the world who are even in a very mature MLP and haven't had an opportunity to do this yet. So Julie, Emily, all yours.
Great, thank you. Thank you so much, Jay, and thank you, Bethany, and the whole National Center team. We're really excited to be here today and share the work that we've been doing and work that we're really proud of. So I think it's fun for Emily and I to talk about this because we've worked on it so long. And I know from the audience, I've been looking at who's here and got some details in advance. I think we have MLPs that are large, that are small, that are new, that have been around, that are in the planning stage. And our goal is really to share our experience, what we did. And, Jay mentioned, we're the largest and the largest. And, it doesn't mean that a small program or a new program can't do this. And in fact, it might be easier. Because being large comes with some more structural challenges. But anyway, we hope we can share our learning and our process and that it's something valuable to you. So just a bit about LegalHealth. We're a division of NYLAG. We provide free legal services and develop policy to help New Yorkers who are experiencing financial hardship and have serious and chronic health problems. We bring together legal and medical professionals in the healthcare setting. We've always say we like to complement healthcare with legal care. I think that sums it up. And NYLAG is a leading nonprofit in New York City that provides free legal services and financial counseling and engages in policy advocacy work to help people experiencing poverty. So next slide, please. So our LegalHealth team of attorneys and paralegals are generalist. As you can see, we handle a wide range of issues. Rather than read from them, it's easier to just say, oh, we don't do criminal and taxes, because it's very broad civil legal services, as you can see. Next slide, please. So our model, I don't think our model is probably that much different than any of your models. We are an MLP, it's pretty standard. We train healthcare providers on health harming legal needs. We have an extensive training curriculum. So that's always, if we're opening up a new clinic, we're going to start with training so people know why we're there and what we can do for their patients. Then providers refer. We have on-site legal clinics at the healthcare facility, and we'll have anywhere from 5 to 6 weekly appointments, usually in an ambulatory setting, though we can go and do inpatient visits. And the hospitals or the healthcare facilities schedule our appointments. That has always been part of our model, is this one-stop shopping concept. The healthcare facility is a trusted environment for the patients, and they're more likely to follow through on the appointment when it is received from their healthcare setting and is held at their healthcare setting. In addition to that direct legal services and training, we do consultations for the providers. They have questions. Is this, my patient's going through this. Is this something I should refer to you? Or just trying to leverage their knowledge. And sometimes avoid referrals altogether because it doesn't really rise to a legal need. We also do systemic policy as issues arise in the work we do. We then do policy advocacy on that. Next slide, please. So it makes sense to talk a little bit about our history with health and hospital system. We're over 22 years old now, and Elmhurst Hospital, one of the public hospitals in Queens, was our first partner in January of 2022. So we started with one site. Through the years, we expanded. By 2014. We had clinics in all of the 11 acute care hospitals within that system. Then in 2016 and 17, we expanded funding through city, both City Council and the Mayor's Office of Immigrant Affairs, to expand immigration-specific work. We were already doing immigration, but this was to add to it and expand clinics within H&H, including 3 federally qualified health systems in the system. And then most recently, in November of 2023, we entered a 3-year contract to provide our services across the entire health and hospital system with Epic integration. So this is a nice snapshot of our history with the public hospital system. And next, I'm going to turn it over to Emily so that she can talk a little bit about H&H.
Thanks so much, Julie, and good afternoon, everyone. Thanks for having me here. I am going to just take a moment to talk a little bit about New York City Health and Hospitals. As Jay said and Julie said, keep saying big. We are big. We are the largest public health system in the country, safety net public hospital system in the country. We serve over a million patients every year, and our patient population is really diverse. So, in a few minutes, we're going to really dig into the nuts and bolts of the work that we've done over the last 5 years to build and embed this medical legal referral and scheduling system into our EHR. But this background about our hospital system, hopefully, and where our work sits and how it's championed, hopefully will clarify some of the unique aspects of our process. So we serve patients, it's important to say, regardless of their immigration status or their ability to pay for care. And our patient population is, of course, incredibly diverse. Our hospitals, our clinics, and our nursing homes are located geographically all across New York City's 5 boroughs. So it's a very disparate, a large geographic area as well. Some of our facilities have been serving New York since the 1700s. So we've also been around a long time. Julie touched on the history of the partnership between Health and Hospitals and NYLAG specifically, and it's one that benefited from strong relationships with individual hospital leadership, as well as very frequently, if not always, the hospital departments of social work. In addition to that, since 2019, the medical legal partnership work at H&H has sat within the Central Office of Population Health, which is where I work. Next slide, please. So this slide, which sort of describes population health as a concept, and I won't read to you, but feel free to read. This is meant to provide more context for our process and our decision making. So Health and Hospitals Office of Population Health is comprised of a team of about 80 people. Collectively, we design, launch, and support programs and initiatives across the health system that aim to improve the health, not just of our individual patients, but of the patient population as a whole. So our programs include primary care and behavioral health integration, specialized chronic disease and management and prevention initiatives, and systems for identifying and addressing the social needs of our patients, things like housing and food security. The Office of Population Health at our health system is driven both by comprehensive data analysis as well as an overarching commitment to equity. And we've been lucky to have a strong commitment from our leadership to the medical legal model in particular. Our Chief Population Health Officer back in 2019 was Dave Chokshi, and he himself is a primary care doctor. He was the first to suggest to our team that the LegalHealth referral could live right within Epic. After Dr. Chokshi moved on to lead New York City's public health department during the pandemic, Nicola Davis, another primary care doctor, took the reins. She's also a dedicated primary care provider, and she has an intrinsic understanding of the limitations of what medical care alone can do to improve health when there's critical underlying social needs involved as well. So Dr. Davis is a wonderful advocate and champion for many of our programs that are designed to address specifically social determinants of health. And I'll talk a little bit more later about why and how this support within our division was so key to advancing our overall strategic and operational priorities. But first, I'm going to hand it back over to Julie with the next slide to talk a little bit about the challenges her legal team faced prior to implementation.
Yeah, so I think it's good to take a step back and what we were trying, some of the things we were trying to work on. And as I mentioned, the hospitals always made our appointments, and that was great, but it was made in different ways. So each hospital site, if we're just talking about H&H, we had 11 sites. There were 11 different ways of making appointments. And generally it was like one person, maybe in the social work office or at some desk, who had this job of, answering the phone or getting emails and making appointments from a schedule that we gave them. Or we had a couple systems that used a hospital call center where people could call and get appointments, but that system was super overtaxed. So it was very hard to get through and actually get the appointments. And then what would happen is providers would call us up and be like, we need to refer someone to you. We can't get an appointment. And we're like, we don't make our appointments. Go back to where you work. And there were a lot of frustrations. And there were inconsistent reminder calls at different hospitals, and because it was dependent on this, limited staff at each site, we found that with reminder calls or text, then clients come to their appointments. If they're not reminded, there's a no-show increase. We like to get our schedules in advance so we can do conflict check, and there were just not weekly, but frequent, issues of getting the schedule in time so that we could do that, methodically and thoroughly. Human error, transferring somebody's phone number into a schedule, their name, things would come up incorrect. And then wide variation in clinic utilization. So we had some sites that would be booked out 4 months in advance, and other sites where you could get an appointment the next week or 2 weeks. And as you have people booked out months in advance, the no-show rate goes up as well. So we really wanted to come up with a system together. It's truly a shared goal of having referrals and appointments made in the same manner as medical appointments. And Emily and I both remember like this day when Dr. Chusky was like, like, you know, I want to make the appointments in the same way as I make specialty referrals as well. I want to get people to you, a specialty clinic, in the same manner as I get them to someone else. And that was a sign that this was going to work. So now we can go to the next slide. And I think we can talk a little bit. Oh, Emily, I think you're going to talk at here.
Sure. Thanks, Julie. Yeah, I was thinking about that day too, when we had the kind of collective aha moment. And it was, I think, for me, it's been a real guiding star through this process, that though we can't do this 100% in every way, it helps me conceptually to think of the legal team as an extension of the medical care team, the way we might think of other determinants like ancillary staff. So I feel like the more we can strive for a model of treating the lawyers and the paralegals as though they are part of the same team, the better the experience for the patient and client is going to be, the more coordinated and the more holistic. So for us, though, at Health and Hospitals, as we thought about how to move forward with this big potential systems change, it was really important for us to clearly identify and articulate how these strategic and operational challenges that we faced could threaten the longevity and sustainability of the program. The biggest one that we faced overall was a lack of patient-level data. We needed to be able to see who was referred to LegalHealth. And we couldn't do that when all of the referral information lived locally at these individual hospitals, like Julie mentioned, and it couldn't be easily organized. Every time we went to seek renewed funding for our contract with NYLAG, we faced questions about the breadth and the measurable impact of the program, something I'm sure many of you working in MLPs are grappling with on a regular basis too. How do we measure the impact? How do we prove this is working? So our leadership wanted us to build a truly data-driven partnership so that we could justify this ongoing investment, as Julie mentioned. It started in 2002 at H&H, so we're 2 decades in, and we want to be able to build and improve and make this even stronger. So we need to be able to show the data. Another challenge for us that Julie mentioned being hard for her staff as well, of course, was this high no-show rate. So for H&H, you know, we have several thousand appointments only annually. I believe it's around 5,000 annually. And we have a very large patient population. So we have to make sure that we are maximizing our use of this really precious resource. Additionally, we knew that access to legal support across our health system was not equitable. Our patients sometimes had to be lucky enough to meet a provider or a social worker who actually knew how to access LegalHealth, how to connect their patients, and that wasn't everyone. We're a big training organization. There's a lot of turnover. Information about how to make local referrals just doesn't always get passed around. So not everybody knew how to make the connection. And we, from our vantage point centrally, had our hands tied a little bit in terms of being able to promote this resource across the system, because again, we had this hodgepodge system of local referrals. And lastly, we needed a system for closing the loop on referrals. So as is so common with referrals that go outside of the health system, our providers ask, they want to know if their referral was effective in helping to connect the patient with legal support. So these were really the key things that we outlined as the big picture strategic and operational challenges. Next slide, please. Yes, so this is a slide that summarizes some of the important people and groups at H&H that we needed to engage. In such a large health system, we had quite a number of key players, and these would of course look different depending on your setting, but it was definitely an important step for us before we got started to really consider who the stakeholders were for this work before we could embark on this big systems change. So we had, of course, our health system leadership. We zeroed in on finance for funding, our legal and compliance teams, sort of getting at some of those issues that Jay alluded to. Start of the webinar about information sharing. It was going to be kind of a whole new ball game doing it in a standard way through the EHR versus the phone calls and emails that had happened more organically over the years. And of course, our HR system, who became really critical as we tried to standardize and centralize a process for onboarding the legal staff. In addition to that, I'll just mention that we have a large system of governance that we had to sort of map out and go step by step over many, many months, the different decision makers for resource allocation, figuring out, again, that centralized onboarding piece. And we knew ultimately that in addition to having staff time dedicated to whatever build process would happen within the EMR, that we were going to need staff to actually manage the system on a regular basis. And so we needed to get some buy-in on that ahead of time. Then, of course, we had our facility-based, our hospital-based healthcare staff who'd been making referrals and managing, from their perspective, the scheduling systems for the legal appointments for many years. So we needed to make sure we had them at the table to seek input and raise flags and share best practices and share challenges and understand how these changes would impact them. Of course, the NYLAG legal health attorneys and paralegals were key stakeholders here too. They were going to be responsible for really implementing the nitty-gritty of the new system and putting it into practice with patients. And last but certainly not least, we try always to keep patients at the center of design and consider how our processes, we sit in some ways a long way away from the patient when we're making decisions in a central office for a citywide system, but we try to get as close to the patients as possible in terms of how we work to support the encounters that the patient's having. Next slide, please. So I'll just briefly walk through this slide, which sort of outlines the three main areas and then sort of sub-bullets of how we organized our strategic goals for this new system. And this is also what we presented more or less to various leadership within health and hospitals. So we said, look, we need to have a standardized system that links the medical team and the legal team. The attorneys need information ahead of time to do a conflict check. It needs to be done in a standardized way. We want to be able to do these automated appointment reminders to reduce this no-show rate so that we're really maximizing the resource. We want equity for our patients, no matter what hospital they walk into, anywhere in New York City, whether it's a big facility or a small clinic, maybe located in a far out part of Brooklyn. We want them to be able to get referred to LegalHealth. We need to be able to do publicity and education. So we need a standard system to do that. And then we need, of course, insight into operational data, which we knew we could get with an Epic-based referral and scheduling system. Once we have all this in place, we said we will improve the quality. And here's how the quality of this program will be improved by having a standardized system. We anticipate being able to have actually higher quality referrals because we can target our training and communications so much more effectively. We can reduce the no-show rate, improve utilization, two sides of the same coin there, of course. We can close the loop on referrals by having the appointment visible right there in Epic. Healthcare staff who place a referral, as well as their colleagues supporting the same patient, can look and see, did the patient get an appointment? Did they attend an appointment? And then we wanted data to inform ongoing decisions as we continue to build this partnership. And over time, we anticipate seeing improved performance and sustainability. So of course, this ability to demonstrate and improve the impact of the MLP intervention itself, and also make more persuasive arguments for ongoing funding. I think, I have one more. Next slide, please. So when we made our case for investment, as I mentioned early on, this was led in 2019 by the Office of Population Health. We identified these challenges, our solutions. We did look at, I will just say, because the question might exist, did we look at anything outside of Epic? We did. We looked at a couple sort of EMR adjacent options, web-based things that might be able to sort of help us have an Epic-based or parallel referral or Epic-based referral and parallel scheduling system. But ultimately, we ruled everything out and decided that we wanted to pursue a full build right within Epic. We did approach an Epic consultant who was employed by Health and Hospitals before the whole process really got going, just to get a sense of like what would be possible theoretically. We sketched out a little bit of like what we thought it would look like. Again, we pretty early on realized that we were going to need to have a centralized onboarding process through our HR department, rather than have attorneys be onboarded locally at these different hospitals where they were actually physically seeing patients, which is how it had worked for 20 years. But processes were a little bit different. Documentation couldn't always be easily accessed, and we needed it for a compliance perspective to have all this onboarding information really easily available. And then once we mapped everything out, we approached compliance and ultimately some related governance committees to get their approval to enter into what Epic calls the discovery process. So that is the many months long, in our case, process of building a solution. So that, you know, in our case for H&H, we couldn't even really move forward to do that exploration and discovery until we had gotten the clear sign off from some of these legal and compliance and clinical leads, I should add. So happy to say, of course, that was successful. And we then were able to secure financial support to hire 2 people centrally who really make up the heart of this work on my team now. These are the people we knew would be sort of running the scheduling process as we got going. And then lastly, I sort of alluded to this on the prior slide, we did seek input from the frontline care teams who had been really struggling to manage the processes locally. Next slide, please. So this is just like an overview, very, very high level of our process. And I just want to mention that the first proposal, Julie and I have now talked about that conversation we had about like being able to refer an Epic to LegalHealth the way doctors might refer to a cardiologist, for example. That conversation was in 2019. We subsequently made a proposal for funding for some of the centralized staff. Also in 2019, we got approval in February of 2020. And then, of course, as we all know, in late February, early March, COVID-19 arrived in New York City, and our hospitals were really on the front lines of the pandemic right away. So everything here was put on hold. Our attention was all turned to, you know, really more pressing matters, if you will. And very happy to say that we were able to continue connecting patients with legal services. But we put the referral, the Epic build for the referral, a little bit on pause. Then we revived those conversations in 2021. So I think the first conversation in 2021 was like around April or May, and it still took us over almost 2 years from that time to launch. So it was a lengthy process for us. But basically, we went through this discovery process. We did the build, the test. Ultimately, we launched. The first pilot site was launched in March of 2023, March of last year. We beefed up our central operations in terms of staffing and then creating onboarding processes, doing training for both our staff internally and also for NYLAG attorneys as they were learning to use Epic and navigate it. And then we launched, did the pilot. I guess the attorney training then happened at that point, and more training for our healthcare teams on how to make a referral under the new system. So that's our process for bird's eye view. And now I'll hand it over to Julie to talk a little bit more about some of the finer points of operationalizing this new system.
Thank you. So my angle is through the sort of my lens. We put together this team, Emily, myself, and the people that they hired. I guess before they hired, it was just Emily and myself, but we started having weekly or bi-weekly operations meetings. So it was a significant amount of time and investment to really work through all the issues so that we could make sure we had a deep understanding, that we both had a deep understanding what the goals and needs were of each side. So we're bringing the client experience and the attorney experience, and she's bringing the provider experience. So we really wanted to make systems that worked for both sides. It was really interesting. Lots of fascinating and learning took place along the way. I'm not sure if this really fits here, but we got a few questions in advance. Somebody asked if we entered a business associates agreement. So I just want to throw in that we did not do that with H&H. Consent, that we're going to get into consent, but we do it on an individualized basis for both healthcare information and legal information. So we did not do a business associates agreement. Next slide, please. So one of our starting points is working together as a group as we were beginning to build the Epic referral system, was to really identify the legal issues that providers could make referrals for. I started with we're all generalists, we're slides, but there's so many subparts, so many different types of housing, so many different types of government benefits. And we wanted to make sure that we had a short list, but gave enough choices so that the providers could find what their patients needed. So that was, a back and forth and zeroing in on that list. One example was Health and Hospital doesn't collect information about patients' immigration status. Immigration was going to be a very large number of the referrals. So used to be people would write down immigration, needs naturalization, needs a visa extension, abused by their spouse. Like they would write a lot of detail. So how were we going to not collect immigration information? So we came up with the terms immigration stressors. So someone could be referred for immigration stressors, and that's a term that we both agreed upon. To use Epic, attorneys had to be cleared through the Health and Hospital clearance system, which most hospitals have some form of clearance. And we came up with the criteria for that. Attorneys could present that they're, attest that they're members of good standing with the bar. That would knock off background and criminal. And then we did the health clearance as well, and that they had to be up to date on their vaccinations and their annual physical. Then there was a training. We did this very early on. We had an attorney talk to Emily's team to really understand what we did. If they were going to start scheduling, they needed to really understand what we did. So we did a little training for them. And if I were to do it again, I would have had them go to clinics and observe our attorneys and see how we interact with our clients or the hospital's patients, so they could see it real time. They eventually did do that, but that was an afterthought, and it would have been great to do that a little bit earlier so they really understood the work. Then we created protocols together, like what the schedulers would say to get ready for the appointment, and like what language they could use when scheduling appointments, the language on, the very specific language for the text or robocall reminders that went out, talked a lot about what's an urgent referral and when somebody should be bumped up to the top of the list. So there was a lot of education back and forth. And then as we were ready to launch, there was training for the legal team as to how they were going to access Epic and what their job was in terms of how they would find their schedule and how they would check people in. And also something that happened toward the tail end that I wish would have happened earlier, but this was a function of, really money, was we were able, because this was so large, we were able to hire a legal program manager with our new contract with Health and Hospitals. And that person has really taken over the operations and the liaising back and forth with H&H, and it's a wonderful role to have. So, you know, a smaller system, just have some percentage of somebody's time earmarked, because even once a bill is billed, there's ongoing issues that are going to come up. Next slide. And I think now Emily will really talk about what the workflow and what they bill.
I know. Thanks everyone for humoring us with all the background. Julie and I in prepping really felt like we wanted to acknowledge that that, as she said, sometimes smaller clinics, smaller partnerships are going to be able to do this so much more quickly than we did. But it is absolutely a function of our size and history that made some of the planning like so complex. So we wanted to make sure that we were really transparent about that and thought some folks might be interested in the details. But now we are going to jump into what it really looks like in Epic. We'll share a couple screenshots just to give you like a flavor of the visuals. This is an overview of our basic workflow. So very simple. It starts with the referral. Our care team member refers the patient in Epic. Now I will say, as you may know, if you are an Epic user, health systems have security profiles, they're called, for Epic users that will either allow you or not allow you, based on your role, to place what's called an order. That's another word for an order is a referral. So we were able to get any Epic user that has the ability to place a referral or an order can place this referral to LegalHealth. There are some key staff who have historically made referrals to the medical legal partnership who don't have access to that referral and never will. So we actually created a parallel system, a secure web form referral that has all the same information, so that we don't, the majority of referrals do come through Epic, but we have like financial counselors, for example, that we want to be able to make referrals, and they're not gonna be able to refer in Epic. So either way, whether you place the referral in Epic or you make it through the secure web form, it's gonna come to a work queue that's managed within the Office of Population Health. The central team reviews the work queue. Regardless of where it comes from, we can see where referrals are coming from, but regardless, we're going to review the referral. We're going to verify that the patient has consented to sharing their information outside of health and hospitals, specifically with NYLAG, and we're going to reach out to the patient to schedule them for an appointment. We'll also typically do, as Julie mentioned, the scheduling staff got some education about how the legal intake process works, and so they're able to do a little bit better job, I think, than historically occurred of screening patients, just making sure, confirming that this is a legal service that they're interested in, right? That they weren't just sent somewhere for help that they didn't really understand. And I think that has also been an important step for us in improving the utilization rate, improving the number of patients who then show up for the appointments, because we're confirming that this is something they want to pursue. Our team also maintains the attorney schedules in Epic, so going out for several months. I'll get into that in a moment. And once the patients have been scheduled, then the attorneys can sign in and see their schedule for a given day. The only documentation that I saw someone mention that their attorneys and their MLP have read-only access to the EHR. So we were able to get the LegalHealth attorneys documentation access, but it's a very limited view. So they're not seeing much of what's in the patient chart. Really, all they're seeing is their schedule. And we customized that schedule view with approval, of course, from our compliance body, with just the most limited information that they need to facilitate the intake appointment, including that conflict check. So then the only thing that we ask them to do at this time in terms of documentation is to mark the patient as arrived if they are able to meet with the patient. So that's the documentation. I think from there we'll go to the next slide and start to look at some of these screenshots of the views. So as I mentioned, any clinical staff who have the ability to place orders in Epic can refer to LegalHealth. We designed it so that people could find it using a variety of search terms. And then this is just a little teeny tiny screenshot of what it might look like to an Epic user once they locate it in their procedures. They're going to select this AM. It stands for ambulatory referral to LegalHealth. It's just a bit of semantics that you can refer from anywhere, the acute setting, post-acute. but it's called AM referral to legal health, since historically most intakes were done in the ambulatory care setting. Next slide, please. And this is zooming in a little bit more on the referral itself. Once the provider selects the referral, you're going to see check boxes where they will confirm that the patient verbally agreed to this referral for free legal aid services to address their health-related social needs in order to further their health or mental health care as part of their overall treatment plan. And also that the patient consented to sharing their contact and appointment information specifically with the New York Legal Assistance Group. We note here in New York State, written consent is required for referrals from any OASS licensed clinic. Those are in New York State, that's the Office of Alcohol and Substance Abuse Services. So it's just very strict requirements in that setting, which we want to make sure folks are aware of. And then the referring provider will select the primary reason for referral. You can see here the main choices we have here are designed around our target population. So while LegalHealth does offer a very broad civil legal services model, at H&H we are working toward, again, this population health driven idea of identifying a target population to maximize use of the resources. And so we have narrowed down a little bit. And after selecting the primary reason for referral, you'll then get what's called some branched logic that will pop up below. So here you see for advanced planning, what pops up underneath is going to be, is this a will? Is this for a healthcare proxy or living will? Is it power of attorney? Is it permanency planning for children? And it's different for branch logic for each one of these primary reasons for referral. Next slide, please.
Emily,
so this is a view of, oh yeah,
Emily,
jump in, please.
It's Jay. Can I interrupt for 1 sec? There was a really interesting question from Lauren Moutry to us, and I just wanted to read it to you folks because it's before you move on to scheduling. It's a two-part question, and if you can just address it quickly. It's the first question on the referral process is it just the referral with a description attached that's housed in the EHR? So maybe you can answer that. And the other one, also I think very interesting as well, is can the families see the order through the patient portal? So the patient portal, obviously a difficult issue on numerous, I don't have to tell you that in terms of the complications of who gets to see what and all the different parameters there. But thinking about, Lauren mentioned family law referrals, potential intimate partner violence issues, So is that referral process transparent in the patient portal, or is it just stay within the confines of the communication between the lawyer and clinician?
Yeah, it's an excellent question and something we grappled with so much during the design of this system, was sort of how do we, with this huge patient population, protect patient privacy and patient safety. And these are not small issues, right? Like it just, as Julie mentioned earlier, this question about immigration status. As many people know, EMRs themselves are subject to subpoena. So we're also thinking about it from the perspective of just like, what is the absolute minimum amount of information that's needed to facilitate the intake appointment? And then basically leaving it at that. And so you can see, I think, so the first part of the question is what's in the referral? And yeah, it's just the reason for referral. We blocked the ability for now, we can always revisit this, but we blocked the ability for providers to enter additional notes because, we find it's almost, it's well-intentioned always that a provider might want to share additional information about the nature of their understanding of the legal need or why they're placing their referral, but we needed to err on the side of absolute extreme caution in terms of what's going into the EMR itself. So it's really like limited to this multiple choice process. And you can see a referral on like an after visit summary, but again, the information is really, really limited. So it's just going to say like referral to LegalHealth. So I hope that answers the question.
Yeah, thanks very much.
Great.
And I would think in terms of
yeah,
privacy, if a patient hasn't given another family, only people who have the access information to the portal. So if I haven't given my husband access to log into my portal or haven't shared my passwords, he can't see it anyway.
We can also try to follow up. I'm just trying to think if I know exactly what the patient portal view looks like. And to be honest with you, I don't, but I will follow up on that. And please feel free to reach out to me offline as well. I'm happy to answer additional questions.
I know that you can see appointment history. So you can, in your portal, you could see what appointments you have coming up and what appointments you had. So at a minimum, a person who has access to a health portal could see that you had an appointment on this date with us.
But
I don't know if it says the details of the reason.
I think that's right. I think it's that you can see the appointment, but not the referral itself, which again is the only place there might be like any information. Thanks, Reha, for the reminder. I think we're getting close to the end, not quite the end, but I will speed it up here a little bit. So yeah, again, just thank you for the question. Like, we really have been thinking about patient safety at every step of the way here. So this is what the work queue looks like to the schedulers. So you see here at the top, this is just an example. There's like two work queues. There's our parent work queue. The Epic architecture refers to a parent work queue and a child work queue. So the parent work queue is like the overall legal health referrals, but then there's individual child work queues for each individual hospital. So we can see either all at once, or we can break them out by where the referral came from. And then, as you can see, there's various information about the patient, the status of the referral, and this is what the central scheduling team uses to guide their outreach to patients to then proceed to schedule for the actual appointment. Next slide, please. I'll just briefly touch on our template management process. This is like real healthcare speak now. But each individual legal health clinic has a scheduling template in Epic. And our central staff manages the scheduling template in terms of the times and dates and number of slots. We have slots slots blocked for urgent needs that will open up only 72 hours before the appointment itself, as well as availability, unavailability, et cetera. These templates are built out 4 months in advance, and they are currently centrally managed. So we designed the system in a way that we could be as flexible as possible. Ultimately, if we want to invite facility-based staff to also be part of the scheduling team, we have the technical ability to do so. And then I think, I did just briefly want to say here about this like overall build that we really didn't create anything brand new in terms of Epic. It all existed with the exception of this like really limited attorney view of the schedule. So we did build and create a new attorney profile. And then it was really just a matter, it took a long time, but a matter of determining which pieces of Epic's existing functionality could we pull from in order to share the appropriate amount of information either with the schedulers or then with the attorneys based on, again, like operational needs, but also compliance regulations, things like that. So I'm going to hand it back over to Julie to talk a little bit about how the attorneys use Epic.
So this is what we see. If I'm logging in, today's my clinic. I am going to see all the schedules. I pick the date. I'm going to see all the schedules that are happening today at H&H by legal health attorneys. I'm going to sort by provider. I don't know if you can see my cursor, maybe not, but I'm going to sort by provider. So I just get my schedule. Let's say that I do Kings County Hospital Legal Health General Clinic, and I'll get a string of 5 appointments there showing me the times of those people. And I click on that first person at 9:30, and I'm going to get all of his information, his address, his phone number, his date of birth. So now we've eliminated human errors. Sometimes clients don't have their records up to date, but we have the same information that the hospital has on the individual, and we can confirm the address and everything with our clients. So it's just very streamlined. We know the legal issue and the reason for referral. We know the language. If it were inpatient as opposed to an ambulatory, there would be an indication for that. And here's the big thing over on the left-hand, upper left-hand corner where it says schedule. All I have to do is click on the check-in button, and then that person will show arrived, and anyone later, the social worker or doctor, anyone can look and see if that individual had his appointment. So it's super easy, very minimal steps for the attorneys, and it's been very well received. So it's great. It's great. And I see a couple questions. Are attorneys able to view documentation and screenings for social needs? No, this is what we see. We see this information right here. We don't get any backup information. And in terms of the other question, concerns related to attorneys collecting information, they could not access to the EHR. We only see this. We don't see any other details about the patient's health. Even if the patient had COVID and we shouldn't meet them in person, we don't get that information. We just get a note that says, do not meet in person. And it would have been moved to, it would be a televisit, not an in-person visit. So they're not sharing any health information with us. And they've built systems that control all of that. Great. Okay, so we're going to go to the next slide. And Emily, do you want to run through, or I can run through this? I think that we've really accomplished our goals. We're not live across all of our clinics yet. We're live at about six different places, but we have more to go. But there is greater access to our appointments, so that patient of a small FQHC in whatever borough can now get an appointment, even if they're not a patient of Bellevue or one of the other hospitals. The ability to check people in allows referring staff to see if the patient came. Fantastic. Data, we're improving our data systems, and we have some more slides on what data is collected. The ability to remind patients through their MyChart portal is fantastic, and our attorneys have commented how the no-show rate has gone down. And I think that our staff are pretty happy with it because it works pretty easily. So next slide. And I think we have a case example next. And this is sort of going to be in the context of not just the H&H system, but all hospitals we work in. There's an issue of people might have more than one doctor, or the social worker didn't know what happened at the first appointment. They re-refer the person. So you have duplicate appointments. And this little story shares and highlights the success of this system. So we have a patient who was referred for immigration. She had an appointment in March. We did a very thorough job, asked to collect some documents, and we're assessing for Medicaid eligibility. The social worker reaches out a month later and says, the patient urgently needs another appointment for Medicaid. They need a liver transplant. So the scheduling team sees this in the patient's record, EMR, that she just had an appointment. She can see a month ago she was there talking to one of our attorneys. So she reaches out to us and says, is this second appointment needed? Because I'd rather preserve it for another patient. The attorney gets back immediately and says, well, I didn't know about the transplant need, but nevertheless, I've got the documents just happened just that day. And she was able to complete her work, and the person was able to, move forward with insurance, etc. So the beauty was, if she had started with a second attorney, a different attorney, it would just keep going, right hand not knowing what the left is doing. And the takeaway is being able to see the history avoids duplication and repeat appointments. so appointments stay available to other people. And now next, Emily is going to talk a little bit about the data, and we're going to really breeze through because we're approaching time.
Yep, agreed. We so many successes, like really hit, I feel like, every single one of our strategic goals, and we continue to work through operational stuff. But I wanted to give you just a picture of like what's possible. So this is a snapshot of what we're able to see. There's lots more, but just to pull some of the key things, we can look at distribution of our patients' ages, their sex, the primary language, whether they fall into one of our high risk categories. Specifically, NYC Care is our program for patients who don't qualify for any kind of health insurance. So we support them with a program called NYC Care for healthcare access, race, ethnicity, and then of course, so exciting to be able to see these health diagnoses start to populate. So we have a sense of like the patients that are referred to NYLAG in terms of this greater population. What are they facing in terms of health problems? That's going to help us down the road as we zero in on really measuring the health impact. Next slide, please. This is another screenshot of one of our scheduling dashboards where we can see number of patients referred and then sort of how it breaks down in terms of the referral schedule rate. The no-show rate hovers around 20%, which is actually like really, really good for our system for specialty referrals. So we're like beating the system standard in terms of our utilization rate, which is particularly amazing, I might add, because we do not overbook as most of our specialties do, or many of our specialties book sort of to the no-show rate, and we're not doing that currently. So it's really great that we're still having this relatively low no-show rate. We can see the breakdown of reasons for referral, as Julie mentioned, heavy need for immigration-related support, and then we can see also over on the right-hand side who's making referrals. Lots of social workers, community health workers, physicians, and then you can kind of go down through the list and see some other smaller representations of staff. For those who are really interested in the utilization rate, like how it varies, and the healthcare metric for access is known as TNAA. It stands for third next available appointment. So we look at the TNAA to get a sense of access. It's a commonly accepted measure of access. Next slide, please.
So just briefly, I think Emily talked about and how when they make the referral, they check the consent that the patient wants this referral and is comfortable giving us their contact information and details. We too collect consent so that we can engage in a data exchange regarding our clients. So we've built, this is a big step for us. We've never done this systematically before. So this was a really big step as part of this contract. But the data is really important. So we built it into Legal Server, the legal database that we use for case management. So right away, if we code our client as a health and hospital client, a consent field comes up where this is a guide for our staff to walk through with our clients to see if they're comfortable sharing their name, date of birth, subject matter of the legal issue, the duration of the legal matter, and sort of the close fields of the legal matter. Sort of we use those IOLA closing fields that shows what happened. And we have two fields. Is the client able to consent? Is the client unable to consent? If they're able to consent, do they release a consent to the release of data in these terms? And also, do they consent to allow us to speak to the referring provider? So in some cases, we need to learn more about the health situation to move the legal matter forward. So both types of consent are requested. Next slide. And it's oral consent. We don't do written consents.
So I think most of these will probably come not at all as a surprise based on our preceding slides, but the challenges we face were certainly like this long timeline. We're talking 5 years from the sort of genesis of the idea, and probably Julie could speak about the years prior to that when she and the legal team thought about ways of addressing some of these challenges. But for me personally, like 5 years we've been at this, it's a long time. It's so rewarding, but certainly has come with challenges. The landscape has shifted in all kinds of ways, The pandemic posed a challenge, as it did to every person on the globe, but it posed a challenge to this overall process as well. The bureaucratic barriers that we had to navigate within, being just part of this very, very large system, competing priorities of all of the key stakeholders, including our leadership. And then there was culture change. Of course, any big change, it signifies culture change. I'll also never forget the day earlier in 2019 when I still worked at a healthcare facility when we went live on Epic. We went from our old EMR, which was called Quadramed, and they flipped the switch overnight and Epic was live. And I'm someone who, I studied systems change as a graduate student. It's what I'm like most passionate about. I've never seen anything like that when it comes to systems change. And I know how these systems that were also dependent on any sort of change in them is really, really challenging. So we've been sort of trying to be really sensitive to all of the ways that, I use the word culture, but it's a big change for everyone involved, most certainly, especially the legal staff. There are communications issues, I think, in terms of our having a remote scheduling team rather than having scheduling teams that are on site present with the attorneys at the same time that they're seeing patients, because when appointments are running late or any other things that just very commonly come up in the course of a day, wanting to make sure that it's communicated to whoever's waiting or whoever may have referred the person waiting, depending on the circumstances. So those are things that we continue to sort of try to address and come up with systems to mitigate. There is absolutely less flexibility under the new system than there was previously. This is sort of the flip side of the coin of the increased need for standardization. With the benefits of standardization, you lose flexibility. And that sort of goes back to, I think, the culture change that I was speaking about a moment ago. Coverage has been a particular challenge that we've been working through when attorneys are out sick or for other reasons, just sort of making sure that we have good systems in place to make sure that, again, patients get called and people get communicated to sort of at the appointed time. And a big challenge is that our centralized team is currently at capacity. So in terms of scheduling, so as we both said, we're live now about half of our health system, and we'd like to implement the system everywhere by the end of this year. So we're looking for ways to increase capacity of our scheduling team. And I think we have like one, maybe two more slides. Next slide, please. I think we're really coming to the end here. Have some time for questions.
I would just share my biggest thing I would change was we checked people in, but we didn't build any information for when clients can't be reached. So we have a mixture of both in-person and telephonic visits. In-person's easy. They showed in the chair, they didn't. Telephonic, left a voicemail. The voicemail is full or non-working. Patient is like at the grocery store, so we can't really do an intake. Patient no longer wants the appointment. These are fields I wish we would have built in, and we're exploring whether we can build those in, because there's a lot of back and forth. I didn't get my call. I did call. This is what happened. And it would just be more efficient if we had a little bit more information to share. And I think that's the most important lesson learned. And we can go on to the next slide and then take questions.
Yeah, I think, thanks, Julie. I think we can sort of, these bullets speak for themselves. I can read them out, but we're just gonna march forward and continue the work and sort of optimize the system, but please start shooting the questions. And Jay, I'm not quite sure if you want us to just like pull them out of the chat or if there are specific ones you'd like us to take first.
Yeah, well, first of all, thank you. And this is an immense amount of information. So I really appreciate both of you and your ability to condense this. I mean, this is like a day seminar, I think, honestly, given the amount of work that has to go into the preparation. And, one really brief observation. I mean, you have to realize, I think, that LegalHealth and the health and hospitals have, been working together for a long time. right? And so there had already been this trust that had been established and a track record of gravitas of the project and the program and the individuals and the leaders, et cetera. So I would imagine, and maybe you've already done some technical assistance on this with other systems, that in a new relationship, so to speak, this is a little bit of a higher ask, because it really does invoke a lot of concerns. And one of them was a question that was posed about, is this a fishing ground for potential legal issues that can be farmed out to other lawyers who may be seeking opportunities, to go after health and hospitals or, private systems or whatever. But, how do you get over, maybe this is the first question, and then I'll get to the question about, who can refer and do the patients have consent on this, et cetera. But how do you get over some of those immediate concerns that the system might have about, well, how are the lawyers going to be put in check? And I understand that the relationship of an MLP is one based on, we're here to work together, not to, be antagonistic. But in some of these larger systems where there may be people who are less familiar with MLP and may have those kind of inherent concerns from the, legal counsel's point of view, general counsel, from the folks who look after liability issues and risk management, how do you get over those? And Emily, you may be able to take this from the systems point of view and the health and hospitals point of view. But how do you get over that? And then how do you, kind of maintain that, trust to get over that initial hesitation?
Thanks, Jay. And so just to make sure I understand the question, how do we convince the risk management and legal entities within our health system to pursue this type of information exchange? And that's sort of really concretized here. Is that right?
I mean, because there's two issues.
I think I can answer it. I can answer it. That was a question that we received all the time, in the initial years of our work, is, are you going to sue us? Like, doctors and lawyers, hospitals, lawyers, they're not thought of as friends and colleagues. They're thought of as adversaries. So we would talk about the legal work that we're going to do. We don't have any expertise in negligence and personal injury. We're not going to do that. That's why training the healthcare professionals is so important, so that they know to refer people who have legal issues within the work that we do. And frankly, by keeping this appointments at the hospital or the healthcare facility, they are in essence screening out people who have, somebody came with a criminal issue. They shouldn't be put on our schedule. The same if they have a personal injury, a malpractice, they shouldn't be put on our schedule, because we don't do that. If somebody slips through, and this is what we would tell the healthcare CEOs, we're going to refer them. We have an obligation to refer them out to the Bar Association or someone else. We're not going to take it. We're going to refer them to the bar. We're going to refer them back to the patient grievance system within your system. But we just tell them, and we don't get that question so much anymore. But we've definitely gotten it, many, many times. And yeah, I'm sure all of you have come across it, because it's a common one.
Yeah, I mean, I think the complicated factor here, Julie, is, obviously if you start an MLP and your first case is to bring an action against your partner, it would be the shortest lived MLP in history, right?
Yes.
I mean, but I do think there's, there's another layer of concern when you talk about, having the ability to look at electronic health records. And I think that there may be some added concern from that perspective. I wasn't certainly trying to downplay the idea of building trust, but your point is a fair one and totally taken.
Yeah.
Another question I wanted to raise that has come up is this idea of capacity or children, minors, who would like to access LegalHealth's resources in the MLP. Are there criteria that you guys have put into place? Does it have to be an issue that, for example, a minor would have the ability to consent to care absent a parent or guardian's, participation because they have that independent right? Is there something that, plays into an adult who may have cognitive limitations or may have emotional issues that are preventing, a potential competency issues? Have you guys been able to think about that, and how does that play into the referral system? And what are their processes that everyone is able to potentially get a referral, or there's some criteria there?
We definitely thought about it, and we have definitely built in systems that children can be referred to our clinics, and Emily can talk. They built in some protocols specifically as to who can give the consent, because that's the first threshold they had to get through, is if they require consent for the appointment, they had to work through who could they collect consent to. So consent from, so even like if it's an adult with a guardian, who is giving the consent? And Emily, I don't know if you remember specifically, but these questions come up all the time. Can they be referred?
Yeah, thanks, Julie. That's exactly right. So our contract with NYLAG funds services, legal services for our patients, right? But we recognize, and our leadership recognizes, that there are situations where a family member may become the client, the actual client of NYLAG. They may not be our specific patient, but they become the client of NYLAG. I think our rule of thumb is, as long as the advocacy is benefiting the patient in the way that the referral was intended, and appropriate consents are in place, then we're supportive of that, and we're able to consider that a fundable service. So we do list the patient who's referred. So if it's like a pediatric patient, a 12-year-old might get a referral because they're living with their family in substandard housing, and the parents' efforts to address the housing conditions have failed, and they need legal intervention. Like, the 12-year-old is not going to become the client of NYLAG, but when the parent becomes the client of NYLAG, hopefully, like, that family situation is going to benefit as a result of the legal advocacy. So you'll see the pediatric patient on the schedule. In this case, we will add into the appointment notes. The scheduler will add that the call or the appointment will be with the parent or guardian, so that the attorney is prepared.
Great, thank you. Here's one from Carly Loughran. Do the in-person appointments occur at the referring health center or in the clinical space? Do you have designated person appointment space that's reserved for the lawyers?
Yes.
Great question. Oh yeah, go ahead, Julie. You want to go first?
No, go ahead.
So yes, it is our goal for, first of all, we like to prioritize in-person appointments. So we offer, I think we didn't say this explicitly, but we have a combination of in-person appointments and televisits. We offer first, if we can, an in-person appointment at the facility where the patient was referred from. But again, there are wait times. And so sometimes there are situations where there's like a sooner telephone appointment available, or even potentially, it's less likely, but an in-person appointment at another facility. So we do really prioritize the in-person appointments over televisits, and use the televisits as strategically as possible. And then, yeah, Julie, do you want to talk a little bit about the space that the attorneys occupy at the hospitals?
Yeah. So space is probably an issue at all across the country, because hospitals are so big, it's real estate. So we always had space, and it's typically, it was either like in an exam room and, a ambulatory medical clinic setting, but it might also be, in the social work office, if they had like a whole designated office suite, and we would take somebody's office for the day. But we're very flexible in terms of what type of space. We would like there to be chairs outside of the space so that clients coming early can sit down while they're waiting. In our actual space, we want a computer and a phone, access to translation services, and confidentiality. So we want space with a door, not a cubicle. So since the pandemic, to be honest, many of our partners are having difficulty finding space. So, you know, we're at 50–60% of our clinics are back in person. But there are pluses to offering telephone visits as well. A person with, you know, serious health issues or age, there are a variety of factors that getting into the clinic setting might be a challenge for some folks. So there's pluses and minuses to have being in person or being by telephone, but it's great that to be able to offer it.
Awesome, thank you. Well, unfortunately, we are out of time. It is past 2:30, so I want to do a couple things. First of all, again, Emily and Julie, thank you so much for a incredibly interesting and thoughtful presentation. It is really remarkable what you folks have done, and really serves as the model for EHR integration in medical legal partnerships around the country. So thank you again for the presentation, for your knowledge, and I know both of you have graciously offered to be resources for folks who may have additional questions regarding this really complex but critically important area. The second is Bethany posted, or Reha both posted a evaluation form. It's right there. Please, please, please do that ASAP if you can. Just, it's really helpful to everyone to hear how we're doing and any feedback that you have. Third, thank all of you for participating, for putting questions in the chat, the Q&As, and for taking time out of your busy day to spend an hour and a half with us and learn a little bit about, again, this really important topic. And then keep your eye on the link that's in the chat for registering for the next session. Kate Marple, an old friend and a wonderful resource, one of the all-time MLP legends, is going to participate in trainings and building effective messaging. And you will definitely learn a lot from Kate in her expertise. And then kind of concluding the process is the June 20th session that will provide, you can go back one slide, Reha, if you don't mind. Thank you. Moving through upstream through partnerships with legal aid. And you certainly should look out for that as well. So thanks, everybody, and we'll see you in a week or so.
Thank you.